It's such a pleasure to be back in India. I seem to be spending more time in India now than I am in Europe, so it's really great to be back amongst you. Look, Khurshid gave a great talk on what it is like to be a true surgeon, new concepts in training, and perhaps I can expand on the specifics of that with simulation and the future of it for surgical training. So look, like all of you here, I am a hands-on surgeon. I might be editing the BJUI, but at the end of the day, I love operating. So at the EAU last year, when the new Da Vinci Xi came out, I had a glass of champagne, I took a photo with the new machine, and I tweeted about it like you do today. It went viral on Twitter. Everyone started talking about it. But I realized very quickly that while the new machine, soon to be in the operating room, is perhaps going to make robotics multidisciplinary, surgical skills alone are not enough. There are three aspects of training and education in robotic surgery, like in any other field of surgery, that you and I need to remember. The first is training in technical skills. The second is training in non-technical skills. And the third, which is absolutely new, came out 2015, I never thought I would see this, is brain training or cognitive training. So let me take you through each of those in brief. The first is how to improve your technical skills. This is a series of simulators, right from the most basic on the left to the most advanced on the right, with Khurshid's ROS machine right in the middle of it, which can simulate the movement of an expert surgeon, say while doing vesicourethral anastomosis. You can follow those movements. You can learn from it. And we published a systematic review with Khurshid on how these simulators work. What do they really give technically to the surgeon? On the left, you will see endo-wrist manipulation right up to the cost. And all you have to look at is the value you get for your money. So while the ROS does nearly everything, it is expensive. The Da Vinci simulator also does everything. Perhaps it is a bit less expensive, but doesn't have the simulated movement of the surgeon. And you have the most basic, which is the SEP, which doesn't do that much. It certainly doesn't track your movements, but is the cheapest. So you need to decide what you get for the money that you spend. And without question, the more expensive the simulator, the better it is, because there has been more technical development trying to develop it. We have validated these simulators. This is a cross-validity randomized control trial, which comes from the University of Keck. This is Dr. Gill's group, looking at whether your performance on one simulator predicts your performance in the operating room, or whether it predicts and compares against performance in a different simulator. And the punchline is, yes, it does. So at least if you're spending that amount of money, then you're getting what you think is good for you and your trainees. So I now recommend that before a trainee goes into the operating room and sits in the neighboring console with me, they spend some time on a simulator, if it is available, that is. Very simple message. Practice safely, but not on your patients. Why won't you practice in a lab just because you have a patient out there? Each time you walk into the operating room, I implore you to think this way. Imagine the patient is a member of your family. And if you're not going to operate on a member of your family without knowing what you're doing, that should apply to your patient the first time you walk into the operating room. Therefore, please spend some time in a lab and then operate on your patients. Let me then take you to the second bit of simulation, which is non-technical skills. This will be new to many in the room because, as I said, like me, most of you are technical surgeons. Non-technical skills involves four things: situation awareness, decision-making, team working and communication, and leadership. Let's start here. This is a cowboy. We are all cowboys because as surgeons we were taught to shoot first and talk later. Unlike physicians who will write long letters, who will make informed choices and decisions, if we sit there at the Da Vinci console deciding whether to cut or not, we would be in great difficulty. Therefore, we are all cowboys. But what can we learn from cowboys? When they move cattle from point A to point B, they have, for over 200 years, used checklists. Checklists do not come from the airline industry, they come from cowboys. This is how you develop a checklist for robotic surgery. So the non-technical skills training starts before the patient moves into the operating room. This is called healthcare failure mode and effective analysis, HFMEA. It is a statistical process whereby you can see what the hazard is at each step of an operation, and then if the hazard score is above 8, you develop a checklist. So this is the checklist which we published in the BJUI. You will notice that in red, the training and the simulation or simulation in real life starts in the operating room. It starts before you do anything to the patient. It then goes on to the operating room, you go through various tick boxes, and it finishes after the patient is transferred to the room where the patient is recovered, whether to go into the ward or into the intensive care. So this is where you have a pink sheet, you have a green sheet, and you have a purple sheet. You have to follow each of those steps with precision and with care. What are the other things you can do to improve your technical and non-technical skills? This is my own skeleton. We can measure the movements of the skeleton. We can put EEG machines. We can put EMG, as you can see on the left. This is a trace of the surgeon as they perform surgery on a Da Vinci console. In O, you have open surgery. In L, you have laparoscopic surgery. And in R, you have robotic surgery. Take a look at the graph in the middle. The higher the score on the y-axis, the more fatigued is the surgeon, and the worse is his or her performance. This shows for the first time that with laparoscopic surgery, you have more fatigue than you do with robotic surgery. Robotics is as good and as accurate as open surgery with lesser fatigue than laparoscopy. It compares and brings the best of two worlds, open and laparoscopic, into robotics. Khurshid already showed you the Dreyfus model. I'll put it to Khurshid that he is right at the bottom, Khurshid. You now have more hair. Look there. I wouldn't call you a novice, but there you are. You might want to buy a pink wig next time. But this then takes the novice, which looks like a joker, right up to the experienced surgeon. And Khurshid very beautifully with his group compared the mental state, the cognitive load, and the high-level engagement at each level of training. This brings the beautiful concept of brain training, which you will notice over the next 5 years. It brings parallels with playing tennis, with playing golf, with going to a football pitch, to being at the best of your performance in athletics. The best athlete is the one who is not just physically strong, but also mentally strong. And I tell you this, watch the space. Brain training of surgeons is going to become vital. There's a lot of investment in the UK in trying to get this right over the next 5 years. You can combine this all into a full immersion igloo. In the igloo, everything is fake. This is an inflatable device. It takes its inspiration from a building of an igloo, which is taught by the Eskimo to their child. You have a full immersion simulation whereby you can put the surgeon through a scenario doing technical and non-technical skills. You can video the entire event, and then you can take the surgeon and the team out and have a debrief without any blame. This has all been put together in 2 curricula. The first was the FRS, which came out of the United States from Vipul Patel. You can read this. This is very clearly developed. And the second comes in the BJUI and the EAU, and this will come from Alex in his OLV talk. This again takes you through a curriculum of training, safe access, e-learning, simulation, and then modular training before you attack your patient. I wanted to finish with this little video. Put the volume up, please.
5,000.
Take a look at this.
Cactus 15.9, departure to contact line, maintain 15,000.
Maintain 15,000, Cactus 1549.
Cactus 15.9, turn left lane 270.
This is Cactus 1539. Hit birds, so you're lost thrust on both engines, returning back towards LaGuardia.
Okay, you need to return to LaGuardia. Turn left heading up 220.
220.
Tower, stop your departures, got emergency returning. It's 1529. He bird strike, he lost all engine, he lost the thrust in the engines, he's returning immediately.
Cactus 1529, which engines?
He lost thrust in both engines, he said.
Got it.
Cactus 1529, if we can get it for you, do you want to try to land runway 13?
We're unable. We may end up in the Hudson.
All right, Cactus 15.9, it's going to be left traffic to runway 31.
Unable.
Okay, what do you need to land? Do you want to try to go to Teterboro?
Yes.
Teterboro, Empire, actually, LaGuardia departure guy, emergency inbound.
Hey, got it.
Cactus 1529 over the George Washington Bridge, wants to go to the airport right now.
Wants to go to airport. Check. Does he need assistance?
Yes, it was a bird strike. Can I get him in for runway 1?
Runway 1, that's good.
Cactus 1529, turn right 280, you can land runway 1 at Teterboro.
We can't do it.
Okay, which runway would you like at Teterboro?
We're going to be in the Hudson.
I'm sorry, say again, Cactus? Cactus 15.9, radar contact is lost. You also got Newark Airport up at 2 o'clock in about 7 miles. Eagle 5 4718, turn left thing 210.
210, 4718. I think he said he was going to the Hudson.
Cactus 1529, Houston.
Ladies and gentlemen, there's a lesson to be learned here. The pilot had practiced a water landing in a simulation lab, exactly as I have been telling you. But it wasn't his technical skills alone that saved the day. Otherwise, this could have been a 9/11 all over. He made a decision that he did not have time to follow what the controller was telling him. He made a decision that he would rather kill himself and everyone on board rather than land into Manhattan. He did a water landing for the first time. It was not just about his technical skills, it was also about his non-technical skills, and above all, his brain training. There's a lesson to be learned here as surgeons. Thank you very much.
Thank you. Very good.